Hi, my name is Aditya Shekhar, and in this presentation, I'll be discussing recent advances in the management of out-of-hospital cardiac arrest. I have no conflicts of interest to disclose. So in this talk, I'm going to be discussing 4 cardiac arrest innovations. But before I dive into those innovations, I want to provide an overview on cardiac arrest science as a field. So cardiac arrest is a state where the heart is unable to pump blood throughout the body, starving vital organs of oxygen and nutrients. And as a result of the vital organs being starved of oxygen and nutrients, irreversible injury begins within minutes. Now, we divide cardiac arrests oftentimes based on where they take place. So we have in-hospital cardiac arrests. These take place within the walls of a hospital. And then we have out-of-hospital cardiac arrests. These take place anywhere outside of a hospital. That can be a person's home, that can be a shopping mall, that can be a public park, that can be the side of the road. And given that these cardiac arrests can take place anywhere, there's some unique challenges that come with out-of-hospital cardiac arrests. So first off, they're challenging in uncontrolled settings. When a cardiac arrest takes place in a hospital, that's a very controlled setting, and not a lot of things are going on, and a lot of things are controlled. When a cardiac arrest takes place in the out-of-hospital setting, that cardiac arrest can take place anywhere. That can be in a patient's bathroom, that can be in a patient's bedroom, that can be in the middle of a shopping mall, that can be on the side of the road, that can be in a park. So that can create a lot of challenges for rescuers, as they have to not only contend with the resuscitation of the cardiac arrest victim, they also have to contend with the dynamic and ever-changing scenes around them. Secondly, there's oftentimes limited resources and task saturation. The number of rescuers who show up to an in-hospital cardiac arrest is oftentimes much higher than the number of rescuers who show up to an out-of-hospital cardiac arrest. So given that you have the same number of things to do, whether that's airway management, obtaining access, providing drugs, interpreting heart rhythms, now with an out-of-hospital cardiac arrest, you have fewer rescuers. So now individual rescuers have more things to do. And we call that task saturation, because the rescuers now have to do more things than they would have had to do in an in-hospital cardiac arrest. And then both of these factors, along with other factors, contribute to low rates of neurologically intact survival with out-of-hospital cardiac arrest. So the bottom line here is cardiac arrest science is an exciting field with significant opportunities for innovation. And as we'll discuss in this presentation, there are a number of cool innovations in the pipeline that have the potential to dramatically improve cardiac arrest survival. So here's some of the innovations discussed in this section. And I want to emphasize that in putting together this presentation, I sort of got to meditate on all the hundreds, if not thousands of innovations in cardiac arrest. And I really had to pick 4. And in 15 minutes, I really couldn't do any of these justice. I want to emphasize that each of these innovations could easily be their own 45-minute talk. And some of these you could devote an entire conference to just a single innovation. But in the next sort of 15 minutes, I want to really provide sort of a flavor of some of these innovations while recognizing that I'm really not doing them justice. But I hope to provide some preliminary research into what the science is showing on them. So the first innovation is the idea of drone-delivered AEDs. So the problem that is sort of in cardiac arrest resuscitation right now is there's limited AED availability. In some communities, there may be one AED for thousands of people. And it's really tough when somebody has a cardiac arrest for that AED to be easily accessible. So one solution that has been proposed is the idea of using drones carrying AEDs that can actually carry AEDs to the scene of a cardiac arrest. So responders and bystanders can actually utilize the AED and help defibrillate somebody if indicated. So here is a photo from a paper published in the New England Journal of Medicine in 2020. You can see there's a sort of drone here, and it's carrying a payload of an AED, and you have a mannequin here that's simulating a cardiac arrest victim. So this idea is that drones may bring AEDs to the scenes of cardiac arrests very quickly. Here's a video from an aerospace company, and I want to emphasize that I have no financial relationship with this company. I just think it's a really cool demonstration. So here we have this drone. It's flying. It's been dispatched to a cardiac arrest. It's making its approach, and this cardiac arrest is taking place in a parking lot, and it lands about 10 or so meters away from the resuscitation taking place. There you can see the rescuers providing CPR. This is a simulation, of course. So the drone lands about 30 meters away, and now the rescuers have an AED for them to use. So they can use it and defibrillate the individual. And so quantitatively, drone delivery of AEDs saves a lot of time. So this is a paper that came out in JAMA in 2017, and they simulated out-of-hospital cardiac arrest and simulated the time it would take for EMS to show up with an AED versus a drone to fly to the scene of a cardiac arrest. And so the median time from dispatch to the arrival of the drones taken from their results section is 5 minutes and 21 seconds, as compared to 22 minutes for EMS to arrive. So in all cases, the drone was able to arrive more quickly than EMS, and that led to a reduction in response time of 16 minutes, 39 seconds. So we're saving a lot of time. And when a patient is in ventricular tachycardia or ventricular fibrillation, that shortening of time can really mean the difference between, a great outcome and a not so favorable outcome. And of course, no adverse events or technical issues occurred during their flight. There are also some things just to keep in mind, however. So number one, there's this idea of guidance, navigation, and airspace restrictions. So as we saw in the video, that cardiac arrest resuscitation was taking place in a parking lot. There was a lot of empty space. The airspace wasn't busy. But if you try to cross-apply that into a busy metropolitan area like New York City, London, Mumbai, Hong Kong, that might be really tough, especially when there's international airports with commercial airline traffic. You have busy airspace with skyscrapers, very congested cities where there might not be very many landing zones. Where will the drone be able to fly safely to the scene of a cardiac arrest, number one? Number two, once it arrives, will it be able to find a spot where it can land safely and deposit its AED? And can it do it safely? Secondly, there's this idea of cost effectiveness. Are AED drones actually a good use of resources? Drones are expensive, and the real comparative in my mind is using AED drones versus just public access defibrillation and just a broad scale campaign of putting defibrillators absolutely everywhere and anywhere. So that's this real comparative. Is this really a good use of resources, recognizing the costs that will likely go into this? And then finally, there's this idea of public adoption and trust. Is this something the public would feel comfortable using? I would hate to be a person in charge of a drone program spending a large amount of money to only have my drones go underutilized because the public doesn't feel comfortable using them. But before we completely sort of write off drone delivery AEDs, I think the next few years will really tell us whether AED drones will be science fiction or clinical reality. So stay tuned for that research. The second innovation I want to talk about is mechanical CPR. So on this slide, I'm showing two mechanical CPR devices. On the left, we have what's called the Lucas device, and on the right, we have what's called the AutoPulse. So there are two different executions on the mechanical CPR idea. So the device on the left, as you'll see, is effectively a suction cup on a piston that moves up and down, whereas the device on the right is a circumferential band that wraps around the patient's chest and compresses the chest that way. The important thing to remember is although you have to interrupt compressions to apply these devices, the compression interruption is minimal, and even while the device is being set up, you can have compressions going. So you can see on the right, the device is applying pressure surrounding the patient, and on the left, you can see the device has been set and now it's providing compressions. And the cool part, as the rescuers on the right show, when these devices are applied, the patient can be successfully transported, and the compressions taking place can be much more effective than oftentimes a manual CPR in the same instance. So those are mechanical CPR devices. And so as we sort of hinted at earlier, CPR during transport is really tough. When you're in the back of a moving ambulance or you're in the back of a helicopter, it's really hard to be able to provide effective compressions, and compression quality really is low, and the effectiveness of the compressions is low. But if you apply one of these mechanical CPR devices, you have consistent compressions, consistent quality, and the compressions can take place during transport with much greater effectiveness than manual CPR. So that is mechanical CPR. So as we discussed, there are some inadequacies to what we'll call human CPR. There's inconsistencies based on training. So some rescuers may not be guideline adherent. They may not follow the 100 to 120 compressions per minute. They may not follow the ensure adequate depth and ensure adequate chest recoil. And there may be differences in athletic ability. Somebody with a lot of stamina can be able to provide CPR much longer than somebody who doesn't have as much stamina. And then finally, there's the spatial relationship between the rescuer and the patient, right? So in a tight, narrow space, like a patient bathroom, or in a back of a moving ambulance or a helicopter, it may be really tough to provide manual CPR. Manual CPR is also limited by provider fatigue, right? So if I am providing CPR and my CPR effectiveness in minute 1 is going to be a lot higher than my CPR effectiveness in minute 5 or minute 10, there's a lot of research that suggests humans can't really perform CPR for that long and still have adequate compression quality. And then finally, human CPR requires a lot of manpower. So if I have 5 people at a cardiac arrest, I may have to devote 2 people to just switch out who's performing chest compressions. If I have 3 people, I may have to dedicate 1 person to just performing chest compressions. And that means that person can't also do other things necessary in a resuscitation, like manage an airway, obtain access, push drugs, monitor the heart rhythm, or do other things necessary in a cardiac arrest resuscitation. Mechanical CPR rectifies a lot of these disadvantages with human CPR. With a mechanical CPR device, you get consistent compression rate and depth when set appropriately. Mechanical CPR by design comes from the factory to be guideline adherent. So it's always going to do perfect CPR unless when set appropriately. Mechanical CPR also doesn't get tired. Its battery far outlasts the stamina of any human rescuer. And even if the battery dies, the battery change out super quick in a lot of these devices. There's also improved workload distribution. If I have a mechanical CPR device, I can just throw that on the patient, have it just do its thing. And now I have freed up providers to do the other things necessary for resuscitation, like airway, drugs, meds, and other things. And then lastly, there's improved CPR quality in the transport environment. Manual CPR is really not effective in the transport environment, and mechanical CPR can really rectify that by just performing consistent CPR even in the back of a moving ambulance or a flying helicopter. So although there's been a lot of really great data talking about mechanical CPR, can we pause the video for 1 sec? No, don't worry about it. Yeah.
Right now?
Yeah.
Hello.
All right, hi, can we pause the video?
Just a minute. So recording started.
So although there's been, as we've discussed, there's a lot of cool advantages to mechanical CPR, but unfortunately, when we look at the data, we don't really see that dramatic improvements with mechanical CPR when compared to manual CPR. So I've sort of picked 4 items from the literature here. I have 2 meta-analyses and I have 2 randomized clinical controlled trials that really show that at best, mechanical CPR has just proven to be non-inferior when compared with manual CPR. So Marcus Ong in 2012 published in the Scandinavian Journal of Trauma, Resuscitation, and Emergency Medicine, a meta-analysis that he found, quote, insufficient evidence to support or refute the use of mechanical CPR devices. Similarly, Bonds et al. In 2016 published in the Annals of Emergency Medicine, they show that observational studies show that mechanical CPR may have some benefit, but the randomized trials really show no benefit. Now let's unpack 2 of what I think are the best randomized clinical controlled trials on mechanical CPR. First, we have the LINK trial, which was published in JAMA in 2014. And they showed that MCPR had no improvements in survival when compared to manual CPR. And this is across 2,589 patients with trial sites in Sweden, the UK, and the Netherlands. A year later in The Lancet, Perkins et al. Published results from the paramedic trial across 4,471 patients in the United Kingdom. Again, mechanical CPR showed no benefits in survival when compared with manual CPR. And one explanation why this might be the case is that mechanical CPR is associated with increased incidence of thoracic injuries. And so the increased incidence of thoracic injuries, this may help explain why mechanical CPR hasn't shown that dramatic of a benefit. A great study by England et al. In Resuscitation in 2008, they looked at 221 victims who were treated with either manual CPR or mechanical CPR, and they did autopsy studies. And they found that mechanical CPR was associated with 37% more sternal fractures, twice as many rib fractures, and an increased incidence of internal organ injuries, such as hemothorax. And these results have been replicated by a number of other studies. With this England paper, we sort of have to contextualize this. These are all patients who didn't survive cardiac arrest. So that may influence the results that we're seeing, but it's certainly important to keep in mind that there is this increased incidence of thoracic injuries with mechanical CPR. The third innovation I want to talk about is called heads-up CPR. So to sort of set the stage here, we'll go to Seoul, South Korea. And Seoul, South Korea is an incredibly industrialized urban center. And they have tiny elevators that were unable to fit patients supine. So when you have a cardiac arrest in an apartment building and they have to get the patient to the hospital, they had to elevate the head in order to fit them in through these tiny elevators. And what they found is that wasn't actually contributing to worse outcomes. And in fact, anecdotally, it may have actually been leading to improved cardiac arrest survival. So there's been a couple studies that have sort of sought to understand why this might be the case. So Ryu et al. In Resuscitation in 2016, they induced VF in 30 pigs, and they randomized them to either be resuscitated in the supine position or with head elevation. And they found that head elevation was actually associated with improved cerebral perfusion. Secondly, Moore et al. 2 years later did a human cadaver study, and they found the same exact thing. When you elevate the head, you actually see improved cerebral perfusion. Now, there's ongoing work right now. It's actually really exciting that there's some of the first human trials are going on right now comparing heads-up CPR with traditional supine CPR. So stay tuned for the results of some of those trials in the next few years. And it'll be really interesting to see to what degree does this improve survival and to what degree does this show a benefit in resuscitation outcomes. And now, finally, I want to discuss the final innovation, which is extracorporeal life support. So extracorporeal life support began with surgical cardiopulmonary bypass. So when you have to perform open heart surgery on someone, you have to stop the heart, but you still have to keep perfusing vital organs. So we invented these devices that can oxygenate, that can remove blood, oxygenate it outside the body, and then put it back in to perfuse vital organs. And that's extracorporeal life support. These machines got smaller and smaller, so they were able to be taken outside of the surgical setting and moved to critical care settings and ICUs, and we got ECMO, or extracorporeal membrane oxygen. Two major types of ECMO. We have veno-venous ECMO and veno-arterial ECMO. Veno-venous is predominantly for pulmonary failure, whereas veno-arterial ECMO is predominantly used for cardiopulmonary failure, so it provides circulatory support as well as pulmonary support. So some of the early trials show that early ECMO in cardiac arrest may actually be associated with improved survival. So we have on the left the ARREST trial, which was published in the Lancet, and on the right we have the CHEER trial, which was published in Resuscitation. So early ECMO in cardiac arrest is associated with improved survival. And I think the coolest part of my entire talk is this idea of portable ECMO. So right now, ECMO in limited capacity, so I think Paris is really amazing at doing this. They are sending physician-led teams out into the field and initiating ECMO on cardiac arrest victims at the sites of cardiac arrest, as opposed to bringing them to emergency departments and cath labs and then instituting ECMO. They're actually cannulating patients on ECMO in the field, and I think this is just the coolest thing ever. So on the left, you have a patient who suffered a cardiac arrest on a subway station, and they're actually cannulating the patient on ECMO on the subway platform. On the right, you have one of the most famous art museums in the world. It's the Louvre. And you had a patient who had a cardiac arrest in the Louvre, and they're actually cannulating this patient on ECMO in the Louvre Gallery, which I think is the coolest thing ever. So that's been my whirlwind tour of 5 innovations in cardiac arrest resuscitation. Thank you so much for your attention. My biggest takeaway that I want you to have from this presentation is every day is an exciting day in the field of cardiac arrest research. I've left my contact info on this slide. You're more than welcome to contact me at any time. And once again, thank you so much for your attention. I really appreciate it.